Good morning, everyone. Welcome to the topic of biopsy as part of the Oral Diagnosis and Surgical Sciences course, Year 3. The learning outcomes for this topic, as outlined, are as follows. By the end of the course, by the end of this topic, you should be able to describe biopsy procedures used in dental clinics, categorize the types of biopsies and identify their clinical indications, demonstrate oral brush biopsies, copy down relevant clinical details in order to communicate with the lab through biopsy requisition forms. Now, I'd like to highlight here that the last two learning outcomes will be dealt with as part of your face-to-face practical sessions when we resume back. Okay, so the aim of my lecture would be to take you through the first two learning outcomes and reinforce it through the Google Classroom. All right, so let's look forward. Right. So the first question that comes to our mind when we talk of biopsy is, what is biopsy? I'm sure you have an idea of what it is, but in terms of description, it is the removal of tissue from a living organism for the purpose of microscopic examination and diagnosis. Right. So basically, it's the removal of living tissue. All right, removal of living tissue for the purpose of microscopic examination and diagnosis. So why submit a biopsy? So the answer to that is to establish a definitive histopathological diagnosis. That means whenever you are in doubt in terms of the clinical diagnosis, you want to confirm the diagnosis, the final diagnosis is always the histopathological diagnosis. The second is to confirm a provisional clinical diagnosis. That means you have come up with a working diagnosis and you want to confirm whether it is that or anything else. Clinical and pathological correlation. Okay, to be able to correlate the clinical and pathological aspects of disease, we do a biopsy. And lastly, to provide diagnostic information to a clinician for the management of disease. Right. So this is the most important aspect, because diagnosis of a particular lesion determines the treatment outcome. Okay, so establishing definitive final diagnosis in order to be able to plan suitable treatment for our patients is the aim because of which we do biopsies. Right. So the next question is, what are the types of biopsies? Right. So broadly, biopsies are categorized into incisional biopsies and excisional biopsies. All right. The word incisional is used when you have a large lesion and you take a small piece for diagnosis. That's when you use the word incisional. Okay. So let me give you an example. For example, uh, let's say there is a very big lesion here, right? And we want to know what this lesion is. Then we actually take a small piece of this tissue, okay, and examine it. And this small piece that's taken from a big large lesion is called incisional biopsies. All right. Excisional biopsies, on the other hand, are basically done for smaller lesions. That means lesions that are less than 2 centimeters. All right, less than 2 centimeters. So they're basically smaller lesions, and so you are able to take out the whole thing in one sitting. That is when you call it an excision biopsy. Right. So the rule of thumb is any lesion that is less than 2 centimeters, okay, you do an excisional biopsy. Anything that is larger than 2 centimeters, you do an incisional biopsy. Right. So the reasons are quite logical here, because it's smaller in size. You can take it out in one sitting, and you're pretty much sure that the smaller lesion is probably benign, all right, less dangerous, and we do not see any complication in removing the whole lesion together. Whereas in a larger lesion like the one here, okay, diagrammatically represented, you're not sure what this could be. You cannot take it out in one sitting because it could lead to severe bleeding on the dental chair, and so you decide to actually take a smaller piece. Okay, so this is a picture from my days of training, when wherein a lady who was 65-year-old came to the dental office with a large ulcerative lesion on the lip, extending from the lower lip right onto the left side of the upper lip. So this is a huge large lesion, right? So to confirm diagnosis here, okay, we would have to do take a small piece of tissue, right? So you probably would take it from multiple sites to be able to confirm it. But when you do take small piece of tissue from a large lesion, you actually it clearly becomes a case where you do incisional biopsy. Okay, so this is where a clear indication of incisional biopsy, for case where we do incisional biopsies. Whereas on the other side, you have this lesion here, which is a growth, right? A growth on the gingiva, a small pedunculated growth, okay, well loculated, and is less than 2 centimeter in size, and so it is clearly indicative of an excisional biopsy. That means we can take this whole lesion out in one surgical sitting, okay, right? So this is how you differentiate cases where you actually need to do incisional biopsies or excisional biopsies. Okay, further on, if we look at the types of biopsies under incision biopsies, they are categorized based on the basically broadly the instrument that is actually used. Okay, basically the instrument that is used. So if we look at it, number one, we have scalpel biopsy, you have punch biopsy, we have brush biopsy where they use a brush, you have scrape biopsy where they scrape out the mucosal surface, right? When bone is taken, it's called incisional, it's called bone biopsy. FNAB, right? The word FNAB is the abbreviation FNAB stands for fine needle aspiration biopsy. Okay, so we will look into it as we go through this lecture. And lastly is frozen section. Okay, so these are different examples of incisional biopsies. Okay, that means large lesions, you take a smaller piece. So when you take it using a scalpel, you call it scalpel biopsy. Punch when you use a punch, brush when you use a brush, and so on and so forth. And we will look into it as we go through further this lecture. Right. So this is a picture of some scalpels that are used by oral surgeons and dental surgeons to do biopsies in the oral cavity. This is a picture of a punch, right? So a punch is pretty much like a ballpoint pen, right? So it has a handle, it has a hub and a blade, all right? So what happens is you push this blade down through the mucosal surface or through the lesion, and then the piece of tissue gets collected in this piece in the blade in the blade, and this is used for histopathological diagnosis, right? So we will look into it as we go uh, and discuss each biopsy procedure in this lecture. Okay, this is an example of brush, right? So this is oral brush, okay, a circular brush which is used to scrape cells of the mucosa. All right, so this is an example of brush biopsy. Right, now this is an example of excisional biopsy. Okay, so if you look here, this is a partially resected mandible. Okay, so there was a growth that was clinically present, and it was diagnosed as a tumor. Okay, it was diagnosed as a tumor on incisional biopsy, and the treatment that was indicated was resection. Right, so partial mandible has been resected. If you look at this is the mandible here. These are the teeth over here. Right, this is the tumor, and these are surrounding muscles and other structures. Okay, so this is an example of excisional biopsy, and if you look at it, this is um, a table where on these biopsies are actually studied. We do something called as grossing to be able to again section them and further study them and come up with our final diagnosis. Okay, right. So let's look at some general guidelines for oral mucosal biopsies. Okay, so mucosal biopsies are one among the most common biopsies that are done in dental offices. So first of all, we always need to be aware of regional anatomy. That means you need to be aware of the nerves, the blood vessels, any important structures that are present in the vicinity of the lesion. Then we select the worst looking area for the biopsy. Okay, we anesthetize around the lesion rather than directly into the lesion. Okay, the reason we do not anesthetize directly into the lesion is because when you inject anesthetic liquid into the lesion, it leads to distortion of cells, which can lead to microscopic misdiagnosis. Okay, which can lead to microscopic misdiagnosis. right? So biopsy, as we study here, is very important in terms of technique. Okay, so in terms of technique, it's very important. We need to make sure that we are aware of the regional anatomy. We need to take care of the worst looking area for the biopsy so that we come up with the correct representative area that needs to be diagnosed, and then we need to anesthetize around the lesion. Okay, with incisional biopsies, it may be helpful to obtain minimal normal adjacent mucosa, right? So as I had actually drawn, okay, in the previous slide, for a larger lesion, you would actually prefer to actually take normal plus lesional tissue for diagnosis. Okay, so this is the lesional tissue here, okay, and this is the normal tissue. Okay, this is the normal tissue. Okay, this is done in order so that we will be able to compare between the lesional tissue as well as the normal tissue, and in many cases wherein we want to know which is the cell of origin in terms of this lesion, is very important to keep this rule in mind. Right. Next is we avoid biopsying the center of an ulcer or a necrotic area. Okay. So what does that mean? Okay. It means that if you have a large ulcerative lesion here, you do not take the biopsy from the central necrotic area. You do not take it from here. The reason we don't take it from the necrotic area is because if you take it from the necrotic area, the cells that you will see would be the dead necrotic cells, and we will not be able to come up with a histological diagnosis, a histopathological diagnosis, right? So the right place to take the biopsy would be, as mentioned in the previous statement, that is including 1/3 of normal and including the the abnormal tissue, okay, and not the necrotic center. Okay, the next important guideline is avoid crushing the specimen with forceps. Right, so for the procedure for biopsy, there is an armamentarium wherein we use forceps to hold the piece of tissue before you actually detach it from the mucosa. Okay, so at that time it's very important that the operator or the assistant should not use excessive amount of force with the forceps and crush the specimen. Again, what goes wrong with using additional force and crushing it is that the cells get distorted, and that could lead to a microscopic misdiagnosis. Right. Lastly is hemostasis with pressure and a suture. Okay, we must use pressure and suture. We must avoid using suction, right, when we're doing a biopsy procedure, because many a times when you're doing mucosal biopsies and you overuse suction, then again it leads to an artifact, or it leads to a microscopic misdiagnosis because of distortion of cells. Right. Okay, so let's now look at the first type of incisional biopsy, which is scalpel biopsy. Let's look at its advantages. So we call it scalpel biopsy when you use a scalpel, as I showed you, right? So advantages is, first of all, you're able to control. You have control over the size and the depth of the specimen. Okay, because based on the size of the lesion, you are able to determine how big a biopsy you need, because it's using a scalpel which is directly is under your control. Okay, this biopsy is acceptable for both freely movable, that is soft palate, floor of the mouth, and bound down tissues such as gingiva and hard palate as well. Okay, so it may produce a more satisfactory specimen without excess tissue, such as in punch biopsy. All right, the drawback is that it is more technique sensitive. That means if you are not trained, if you are not if you do not keep in mind the guidelines that we just discussed while doing this biopsy procedure, then it can lead to uh, unnecessary use of this technique, or uh, wrong specimen, or wrong representative tissue. All right. Okay, so for the armamentarium, you need, first of all, we need local anesthesia, number 15 blade, forceps, scissors, suture and needle, a needle holder, and sterile gauze. Okay, so Okay, so let's look at this case example here. So we have this patient who has actually come to us with a white patch, which is a homogeneous leukoplakia affecting the right lateral and the ventral areas of the tongue. Okay, so if you look at this, this is a homogeneous patch. Then you have here, which is a whitish patch and a slightly reddish area here. So these are the steps that are actually done in before in the process of taking a scalpel biopsy. Okay, so this is a clear case of indicated for scalpel biopsy. So the first step is you've identified the lesion, you've identified the site. Okay, so you give the second step is picture B, wherein there is an infiltration being given around the lesion. All right, the third step C and D is where um, an elliptical incision is being traced and is done using the scalpel. An elliptical incision is given around the lesion. All right. Thereafter, the anterior edge of the ellipse is gently raised with a tissue forceps, which allows the detachment of the ellipse-shaped tissue. Okay, and once that's detached, you use the scissors and cut it out and detach it from the mucosa, and then the biopsy is taken. So that piece of tissue is immediately put into um, the specimen container, which has 10% formalin in it, and the raw area that is actually present is then sutured up. Okay, so this is the steps that are followed in um, scalpel biopsy. Okay. Okay, so now let's look at punch biopsy, right? So when you use the device called punch, then you call it a punch biopsy. The advantages are, first of all, ease of technique. Sutures may not be required if a small diameter punch is used, and it may produce a more satisfactory specimen in bound down tissues. Okay, especially for example the lesions that are on the hard palate. Okay, so the drawbacks, however, may be that the specimen may not be adequate for deeper pathologies because it is restricted by the depth of the blade. Okay, and it may be difficult to biopsy freely movable tissues, for example the soft palate and frozen mouth. Okay, right, so this is the armamentarium for punch biopsy. So this is here the punch that we have. Okay, this is the punch. You need curved scissors. Right now, this is a very beautiful photograph, a diagrammatic representation that I've found, and I love to discuss this with my students always. So here, actually, if you look at this diagram carefully, you have the hands of the operator with the punch here. Okay, so this is the handle, this is the hub, and this is the blade. So here they are actually trying to biopsy the pigmented lesion on the skin, right? So if you look at, this is the lesion that they're trying to biopsy. Now if you look at the left right corner, then it shows you a zoomed in view of the operator, wherein the diameter of the punch is involving normal tissue as well as the pigmented piece of tissue. Okay, so while you decide the site of biopsy, the location of the biopsy, you are technically picturizing what you intend to biopsy. So if you look at the upper left corner, then you are actually seeing that the blades are actually going through normal tissue as well as abnormal tissue, which is actually the aim of uh, doing a biopsy, right? Okay, and if you look at this picture diagram carefully, you will also note that the depth of the biopsy is determined by the depth of the blade. Okay, which is a drawback in some cases of the punch, and in some cases it is an advantage as well. Okay, so a punch biopsy is a very good type of biopsy for skin lesions, for pigmented lesions in the oral cavity. They are best suitable for lesions on the hard palate. Okay, right. Okay, so let's now look at the third type of biopsy procedure, which is called as exfoliative cytology. Alright, the word exfoliative cytology and brush biopsy are actually used pretty much interchangeably. Okay, so basically what we do here is basically surface mucosal epithelial cells are scraped off. Okay, are scraped off. So when you're actually basically epithelial cells in the mucosa actually exfoliate uh, once they mature. Okay, and the aim of this type of biopsy is to basically examine those cells that can that exfoliate or that can be scraped off under the microscope to be able to determine if there is any underlying pathology. Okay, so here you're actually seeing a brush that is used to scrape out cells, and here you're actually seeing a wooden spatula that is actually used to scrape out cells. Okay, so the procedure is pretty much simple. Basically, once you have scraped the cells from off the mucosa, you actually spread it onto a glass slide. All right, basically roll the brush over, or you spread it using the spatula, and then you use a spray fixative. Okay, and dry the slide, and then transport it to the lab wherein they stain it, and they stain it, and then they examine it microscopically, and they are able to tell you if the morphology of the cells is normal or abnormal. Okay, so this is an example of a non-invasive procedure. Patients are very much willing to get it done. It's indicated in cases where you are not able to do a scalpel biopsy, or the patient is not willing to do it. You also use this procedure as a screening tool. Okay, as a screening tool to screen patients who have uh, precancerous lesions. Okay, precancerous lesions. Okay. All right, let's look at brush biopsy now. All right, so brush biopsy and exfoliative cytology, as I mentioned, basically are interchangeably kind of used, but there are specific brush biopsy kits that are actually available in the market, which are actually patented and are actually marketed as tools that have very high specificity and sensitivity in terms of diagnosis. And one such example is actually oral CTX. Now, oral CTX, I like to discuss it here for with students here, is because it is one of those brush biopsy techniques wherein the biopsy is done using a brush, a kit which comes from the lab, from the oral CTX lab, and once you do the smear, you send it back to the lab, which is based in the US, and then they use technology. Okay, they use technology to basically scan through the slides using advanced technology to be able to detect abnormal cells. Okay, and I'll show you how an example of the report. And because it is done automated, there is a very high degree of sensitivity and specificity of this diagnosis. Okay, all right, so oral CDX is a type of brush biopsy to test benign appearing common white or red spots that would not have been selected for biopsy. Okay, so the brush basically looks like this, and its indications are invasive biopsy where invasive biopsies are not suitable. There's a lack of patient acceptance, lesions that require long-term histological follow-up, multiple successive invasive biopsies are not practical. Okay, these are important indications where you would want to do oral CTX. Advantages: ease of the technique, it's non-invasive, as I told you, patient acceptance is very good. So the drawbacks are lack of tissue architecture. Okay, obviously cannot appreciate tissue architecture because these are cytologies. That means two-dimensional images or two-dimensional visualization of a three-dimensional structure. Okay, so basically we're scraping the cells, epithelial cells, putting them flat onto a glass slide, and then we're trying to visualize them. So we're not able to see the association of those epithelial cells with fellow epithelial cells as part of the tissue. Okay, that's what this means. Reactive changes may mimic atypical changes on interpretation. Okay, so this is one of the drawbacks. That means if you are actually going to do a brush biopsy of an inflammatory lesion, then generally the inflammation can mimic like a malignancy, and obviously you need experienced pathologists to be able to distinguish that. Okay, it's not useful for the diagnosis of pigmented or connective tissue lesions. Okay, that is one of the drawbacks of brush biopsy. Okay, so this is the diagrammatic representation. So basically the brush is scraped onto the epithelial cell on the mucosa, and the mucosa here is showing cells that have different sizes of nuclei, that are different grades of chromatism, so all indicative of abnormality in the epithelium. All right, and then these cells basically get attached to the bristles over here, and when you these cells get attached to the bristles over here, and when you actually spread it onto the glass slide, these cells appear flattened out like that. However, despite they being appear flattened out, we are able to visualize. Okay, so the brush biopsy kit comes as something like this. Okay, it has a pre-coded glass slide and the matching coded test requisition form, alcohol fixative, pre-addressed container for submitting contents. So all you have to do is to identify the site, rotate the brush on the lesion to be to collect the sample, then spread the cells on the glass slide. Okay, spread the fixative, pour the fixative, and let it dry. And then you actually send it off to the lab, and the lab, after interpretation using automated um, algorithms, okay, using algorithms, computerized algorithms, comes up with images of abnormal cells as well as measurements of the nuclear cytoplasmic ratio, the nuclear diameter, and various other parameters that are indicative of ATPR. ATPR means abnormality of the epithelial cells. Okay, so for those of you who are not familiar, all epithelial cells, before they become malignant, they always undergo something called as atypical changes. That means changes which indicate that the cell is going to turn dysplastic or has turned dysplastic and has a high chance of turning into cancer. Okay, so as we progress through the ODSS course, we will be going through this furthermore in detail. So the aim here basically is that as a dental surgeon tomorrow, when you identify these suspicious lesions in the oral cavity, it is important to do a brush biopsy so that you are monitoring these lesions and we are able to give our patients an early diagnosis. Okay, our success as a dental surgeons in the management, in the awareness of oral cancer, is to be able to detect cancer early, not to detect cancer late, and that can only be done if we keep an eye of suspicion on oral lesions and do brush biopsies to be able to identify if there is any atypical changes that are taking place. Okay, all right, so this is basically oral CDX. Okay, now these are actually images of lesions, okay, as we discussed in the previous slides, which are not suitable for brush biopsy. Okay, so these are two pigmented lesions on the mucosa, and this is a connective tissue growth. Okay, so we cannot do a brush biopsy because you will not be able to get representative tissue to be able to come up with a diagnosis. Okay, so this brings us to the end of the first part of my lecture on brush biopsy. Next week I will be discussing other biopsy techniques as well as the importance in terms of um, biopsy requisition filling out. Okay, so thank you very much.